to life in general, and drag will be oxygenated by adults. Important, and any lesion affecting the well-being of the respiratory system threatens the well-being of an individual. So the normal lung anatomy comprises of the chest wall, pleural space, the lungs, the airways, and the terminal air sacs or alveoli. Below it will be boundaried by the diaphragm, which helps in the respiratory movement. As you know, we have two sets of lungs, various structures exist in the lung, starting from the airway, the bronchus, the main trachea, the bronchus, the primary and secondary bronchi, tertiary bronchi, bronchioles, and finally forming the alveolar structures composing alveolar duct and alveoli. So any structure could be affected by various disease processes. When we see the histology, the airways are lined with pseudostratified respiratory epithelium, followed by some mucosa, which contains glands, secrete muci, and there will be sort of the cartilage till some degree of anatomy. You see this ciliated, pseudostratified respiratory epithelium. The cilia is very important in removing foreign large molecules which interact by breathing in. Okay, audio እየተሰማችሁ አይደለም? አንዳንድ
ይሰማል ግን
አንዳንዶች በደንብ አይሰማም እያሉ ነው። this is the best I can do። እንግዲህ በማጆሪቲዎቻችሁ የሚሰማችሁ ከሆነ መቀጠል እንችላለን። አሁን ሲሰማል እስቲ ያው አሁን ለውጥ አለው ከቀደሙ?
አሁን ይሻላል።
ኦዲዮ ከቀደሙ ለውጥ አለው በዚህ መልኩ ሲሆን?
አሁን ይሻላል።
እሺ፣ ስለዚህ በዚህ መልኩ እንቀጥላለን። So as we are saying, the cilia is important in removing large molecules which enter by inhalation. That could be dust particles or any other foreign materials which should be removed by this movement of the cilia outwards. And the goblet cells secreting mucus also entraps this kind of materials to remove from the system. Here you see the parenchyma of the lung, which forms the alveolar spaces, and these alveolar spaces are lined by the thin layer of space. This is important to maintain the well oxygenation of the blood. So if anything that disrupts this layer, each individual layer, will affect the oxygenation process of anything affecting the parenchyma, be it if there is expansion of this layer by inflammatory cells or by edema, everything will affect the oxygenation process, then impacts the whole system. So only air should enter in this layer of the alveolar You find blood capillaries, which carries the oxygenated blood, and the gradient will, the oxygen gradient will move into the capillaries, so the oxygen will be carried by the red blood cells, hence the process of oxygenation takes place. So as you see, there is a thin barrier made by type 1 and type 2 pneumocytes and very few macrophages, and this is very important to maintain the oxygenation of the blood adequately. So microscopic structure of the alveolar walls forms the blood-to-air barrier, the capillary endothelium, a basement membrane, and surrounding interstitial tissue separating the endothelial cells from alveolar lining endothelial cells. Then you find the alveolar epithelium, which is made by type 1 and type 2 pneumocytes, and you will find alveolar macrophages. So this is the alveolar space. So what could go wrong? So this is an important organ. It carries the air, purifies it, takes it to our lung, and delivers the oxygen to the blood, and hence all organs get the adequate amount of oxygen to function. Many things could affect the lung, be it congenital, be it inflammatory, neoplastic, or any other disease entities can affect the lung. So when we start from the congenital anomalies, a patient could develop pulmonary hypoplasia, and you understand what we mean by congenital. So these are lesions that occur in utero and manifest at birth. Pulmonary hypoplasia are defective development of those lungs, resulting in the decreased weight, volume, and asthma compared to body weight and gestational age, and is most often secondary to space-occupying lesion in the uterus, or if the patient have decreased amniotic fluid, which we call oligohydramnios, as in the case of diaphragmatic hernia, renal cyst disease, renal agenesis, prolonged premature rupture of fetal membrane, all could result in hypoplasia. So you understand when we say hypoplasia, it is the decrease in number of the cells that form that organ. So this could happen if there is any space-occupying lesion in the uterus, like let's say the patient has a tumor in the uterus which is occupying the space and impairing the normal development of the structure. So you see this is an abortus, and here you see this structure is the liver, and this patient have diaphragmatic hernia, and the liver has occupied the upper chest, and you only see buds of lung. Otherwise, there is nothing in the pleural cavity. Again, you see the hernia placing the liver in the upper chest, and you don't see any development of the lungs. The other lesions are what we call pulmonary sequestrations. So pulmonary sequestration is the presence of lung tissue without any normal connection to the airway system. So if you find a portion of the lung that is not connected to the airway, that portion of the lung is not getting the air needed or is not expanding. So extralobular sequestrations are external to the lung, found anywhere in the thoracic or mediastinum, while intralobar sequestrations are within the lung substance and are usually associated with recurrent infections and dilatation of the bronchi. So sequestrations could be intralobular. You may find inside the parenchyma of the lung or outside the parenchyma of the lung, which is separated from the lung tissue. Those are like dead spaces and are prone to cause infections. The other disease process that could occur in the lung are atelectasis. Atelectasis refers to either incomplete expansion of the lungs, like in neonatal atelectasis, or to the collapse of previously inflated lung occurring in adults. Atelectasis could be divided into these components, could be resorption or obstructive atelectasis, compression atelectasis, or contraction atelectasis. When we say resorption atelectasis, it is a consequence of complete obstruction of an airway, and the air already present gradually becomes absorbed and alveolar collapse follows. So depending on the level of the airway obstruction, an entire lung or complete lobe or one or more segments may be involved. So if the obstruction occurs higher in the bronchus, the entire lung could collapse and there could be atelectasis. If it's in the primary, secondary, or tertiary bronchus, depending on the level where the obstruction is occurring, this atelectasis may happen. And since the lung volume is diminished, the mediastinum shifts towards the collapsed lung. The most common cause of resorption collapse is obstruction of a bronchi by a mucus or mucopurulent plaque, and this frequently occurs post-operatively but may also complicate bronchial asthma, bronchiectasis, or chronic bronchitis diseases, usually which are incriminated in production of high mucus due to pathophysiologic nature. Sometimes obstruction is caused by the aspiration of foreign bodies, especially people who are unconscious, who are old age people, will have this recurrent aspiration of foreign bodies, like food, if they are choking into food particles and the like. Particularly, children will encounter this choking hazard because they swallow tiny things and may aspirate them. Or blood clots during oral surgeries or anesthesias may also cause atelectasis. And usually after surgery, we encourage patients to do chest exercise by either inflating a balloon or having to inflate something which is harder. With that way, the sequestration or the blockage may resolve by the exercise. Airways may also be obstructed by tumors, especially tumors occurring in the bronchus, we call them bronchogenic carcinomas, or by enlarged lymph nodes. For example, if a patient is having tuberculosis or sarcoidosis, if there is an enlarged lymph node which is able to compress the bronchus, and rarely by vascular aneurysms, all may obstruct airway and bring about atelectasis. So compression atelectasis, tumors, pleural effusions, pneumothorax, and the like could cause that. The other compression atelectasis, sometimes it's called passive or relaxation atelectasis. It is usually associated with accumulation of fluid, blood, or air within the pleural cavity, which mechanically collapses the adjacent lung. So in the pleural cavity, if you find excessive fluid or blood or anything, the lung cannot expand, so there will be atelectatic changes. This is frequently occurs with the pleural effusion caused by congestive heart failure or neoplastic effusion if there is metastatic lesion to the pleura. Leakage of air into the pleural cavity due to maybe trauma or traffic accident or any injury caused by penetrating traumas lead to what we call pneumothorax, and this also leads to compression atelectasis. Basal atelectasis resulting from the elevated position of the diaphragm commonly occurs in bedridden patients and in patients with ascites and in patients during and after surgery. With compressive atelectasis, the mediastinum shifts away from the affected lung. So you see in the pleural cavity, it could be air, blood, or metastatic deposits causing excessive bleeding or anything. This leads to compression atelectasis. The other is contraction atelectasis. Occurs when either local or generalized fibrotic changes in the lung or pleura hampers expansion. So in general, there is resorption, compression, and contraction atelectasis. Atelectasis is a reversible disorder except when it is caused by contraction because the parenchyma is already contracted due to various pathological conditions. It's like a scar has already formed when it's contraction atelectasis. Otherwise, if you remove the load, if it's a pleural effusion, you could tap the effusion. If it's a lymph node, removing the lymph node and the like will reverse this disorder. Do you have any comments, questions? No? ተኝታችኋል? ግማሾቻችሁ አይደለ ኦንላይን ገብታችሁ? አልተኛችሁም? እሺ ዮሐንስ, thank you. So when we continue, the other group of disease are called acute lung injury or ALIS. This is a spectrum of pulmonary endothelial or epithelial lesion which can be initiated by various factors. It may manifest as congestion, edema, or atelectasis, and this may progress to acute respiratory distress syndrome. So the point here is, whichever disease has instigated or started it, the point here is the lung is failing. It is functionally altered. And it is usually mediated by cytokines, oxidants, and growth factors such as tumor growth factor, interleukin 1 and 6, transforming growth factor beta, and this causes pulmonary edema. And if anything is found in that thin layer of the alveolar wall, as we said earlier, the normal oxygenation process will be hampered. So anything that thickens that thin layer of alveolar wall will result in massive impairment of oxygenation of blood. So hemodynamic pulmonary edema is due to increased hydrostatic pressure, such as in left-sided congestive heart failure. Edema caused by microvascular injury is due to injury of the capillaries of the alveolar septa. This results in leakage of fluid and proteins first into the interstitium and, when severe, to the alveolar. So this all results in acute respiratory distress syndrome, or we call that diffuse alveolar damage or DAD, or we call it shock lung. So this is a clinical syndrome caused by diffuse alveolar capillary damage, and it is characterized by rapid onset of severe life-threatening respiratory insufficiency, cyanosis, and severe hypoxemia refractory to oxygen therapy. Even if you administer high liters of oxygen, if the wall is not penetrable, or if the wall is thick enough, and instead of the oxygen or the air you're pumping in, if the alveoli is filled with fluid, you cannot do anything in this scenario. So this it may progress to extrapulmonary multisystem organ failure. Morphologically, in acute stage, the lungs are heavy, firm, red, and bulky because of the edema and exudates, and they show congestion, interstitial and intraseptal edema, inflammation, and fibrin deposits will be seen under the microscope. So the alveolar wall becomes lined with a waxy hyaline membrane that are similar to hyaline membrane disease occurring in neonates born earlier than their time. So you remember the image we saw for the normal alveolar wall. Here you see inflammatory infiltrates and hyaline and edema expanding that alveolar wall, making the barrier between the capillaries and the air so much significant that the normal oxygenation of blood can take place. So ARDS is complication of diverse conditions, including both direct injury to the lung and systemic disorders, and central to the causative cause of ARDS is diffuse damage to alveolar capillary wall due to various disease conditions. Clinically, the patients are usually hospitalized, and profound dyspnea and tachypnea Herald yes. There is increasing cyanosis, hypoxemia, and respiratory failure. And once, for whatever reason, a patient is diagnosed to have acute respiratory distress syndrome, the prognosis is quite good. The other important disease categories you encounter in your clinical practice is obstructive and restrictive pulmonary disease. So these pulmonary airway diseases can be classified into obstructive diseases and restrictive diseases. When we say obstructive diseases, or in a broad term as airway diseases, these are characterized by limitation of airflow, usually resulting from an increase in resistance from the partial or complete obstruction at any level of the airways, starting from the trachea to the bronchus to the terminal bronchi. In these patients, pulmonary function tests show limitations of maximum airflow rates during forced expiration, because there is obstruction of the airways by different reasons. The forced expiratory rate will be restricted. The other broad categories we call restrictive disease. These are characterized by reduced expansion of the lung parenchyma, accompanied by decreased total lung capacity. So the obstructive are obstructing the airway, the channel that takes the air inside, while restrictive is even if you deliver the air, the lung is not expanding to take the delivered air into the parenchyma. So this is restricting or restrictive. So the difference is obstructive is an airway disease, while restrictive is a parenchymal lung disease. It is like the lung has some degree of fibrosis, which hampers its expansile or coil nature. Restrictive diseases occur in two general conditions. Either the lung is not expanding due to chest wall disorders in the presence of normal lung, or acute or chronic interstitial or infiltrative disorders, making the lung hard itself. So a person with a chest wall deformity like scoliosis or deformed chest may have a normal lung, but even if the lung wants to expand, the physical barrier of the chest wall is holding it not to expand. Or the lung itself has a parenchymal lesion leading to contracture of itself. So in the obstructive pulmonary disease, this disorder includes emphysema, chronic bronchitis, asthma, and bronchiectasis. Emphysema and chronic bronchitis are clinically grouped together and referred as chronic obstructive pulmonary disease, or COPD. Usually, both of them are seen in single patients most of the time. So we start with emphysema. So is it characterized by permanent enlargement of the air spaces distal to the terminal bronchioles, accompanied by destruction of their wall and without obvious fibrosis. You're following me, Adela? If you have questions, text ሳይሆን በቮይስ ግቡ። እሺ፣ ችግር የለም ላላዩ ስለምችል። እሺ፣ let's continue. So emphysema is characterized by permanent enlargement of the airspace distal to the terminal bronchioles, and accompanied by destruction of their wall and without obvious fibrosis. The types of emphysema are classified according to anatomic distribution within the lobule and acinas. So there are four major types: anacina, pan means the whole; centriacinar, central to the acinal; parasectal, and irregular. So when we see centriacinar or centrilobular emphysema, the most common type associated with airflow obstruction is intracinar emphysema, and the distinctive feature of this type of emphysema is pattern of involvement of the lobules. The central or the proximal part of the acina is involved, formed by the respiratory bronchioles are affected. So primarily, the respiratory bronchioles will be affected in centriacinar emphysema, while the distal alveoli are spared. The lesions are more common and severe in the upper lobe, particularly in the apical segment. And this type of emphysema is most commonly seen as a consequence of cigarette smoking. Most airway diseases are incriminated with cigarette smoking and pollutions. Panacinar emphysema, in this type of emphysema, the acinars are uniformly enlarged from the level of the respiratory bronchioles to the terminal blind alveoli. In contrast to centriacinar emphysema, panacinar emphysemas tend to occur more commonly in the lower lung zone, and this type of emphysema occurs in patients with alpha-1 antitrypsin deficiency. So, this is the normal, This is the normal alveolar. You see it is composed of respiratory bronchioles, alveolar duct, and alveolus. When we talk about centriacinar emphysema, the dilatation is occurring in the respiratory bronchioles, while the panacinar, you see dilatation in the alveolar duct as well as the alveoli, and even some degree in the respiratory bronchioles. So you see the normal alveoli and acinar structure, centriacinar and panacinar. So the entire acinus, panacinar. Proximal bronchioles, centriacinar. Distal acinar or paraseptal emphysema, in this form, the proximal portion of the acina is normal, so the bronchioles are normal, but the distal part is dominantly involved, and the emphysema is more striking adjacent to the pleura. So along the lobular connective tissue septa and at the margin of the lobules. This occurs when it occurs adjacent to the areas of fibrosis, scarring, or atelectasis, and is usually more severe in the upper half of. So this is distal acinar or paraseptal emphysema. So it involves the terminal alveolar ductus and the blind alveoli, which is usually found around the center. So the final type is irregular. So this means the acina is irregularly involved and it's invariably associated with me. You see part of the one acina is located in the center, on the other in the distal. So because of irregular. So it involves all structures at different levels. Of reactive oxygen species in the alveola, A secondary consequence of oxidative injury is an activation of native antitrypsinase, resulting in functional alpha-1 antitrypsin deficiency even in patients with enzyme deficiency. So if there is chronic inflammation going on or acute inflammation going on repeatedly, the patient may be exposed to develop that. So smoking and pollution are the central actors in emphysema or airway obstructive airway disease problems. Morphologically, panacinar emphysema, when well developed, produces a pale voluminous lung, and the microscopic features of centroacinar emphysema are less impressive. Generally, in centroacinar emphysema, the upper two-thirds of the lung is most severely affected, and the lower lungs, and in extreme cases, emphysematous bullae may be closely visible. Bullae is an air-filled circular membrane-covered structure occurring at the pleural surface. The part side about developing a bullae is it could rupture and the air may leak and pneumothorax may occur, which is a life-threatening condition. So when you see the lung, you see this spongy-like consistency, and you see this dilated alveoli here and there. So this is an emphysematous lung. Again, you see sponge-like dilatation here and there. This is a bullae. So in the pleural space, there could be air-filled sacs, and you see bullae. And if this bullae rupture, there could be leakage of air into the pleural cavity, leading to pneumothorax. Here you see. Histologically, there is thinning and destruction of the alveolar wall. With advanced disease, adjacent alveolar becomes confluent and creating large airspace, like the one you see. Grossly, microscopically, you see a huge confluent air spaces. You cannot even call it alveoli because they are already damaged and have, you see, large confluent spaces. Clinical course, clinical manifestations do not appear until at least 1/3 of the functioning lung is damaged. That is the big reservoir. Dyspnea is usually the first symptom. It begins insidiously, but is steadily progressive. Patients with underlying chronic bronchitis or chronic asthma bronchitis, cough and wheeze may be initial complaints. Weight loss is common. Pulmonary function tests reveal reduction in the FEV1 with normal or near normal FVC. Hence, the ratio of FEV1 to forced expiratory volume 1 to the vital capacity is reduced. The classic presentation in individuals with severe emphysema is a patient is barrel-chested and dyspneic, with obviously prolonged expiration, and they usually try to support their lung by leaning forward. Leaning forward helps push the diaphragm up and will try to remove the air that is trapped inside those dilated spaces to move out, to go out. So they will ideally, or they will practically squeeze the air out of their lung mechanically. So they will sit forward in a hunched over position, attempting to squeeze the air out of their lungs with each expiratory effort. So they will try to breathe out longer because they are trying to take all the air which has sequestered in that space out. In this patient, space enlargement is severe and diffusing capacity is low, leading to dyspnea. So if there is diffusing capacity is low, it means the oxygenation is low, and the peripheral organs will signal hypoxia. This leads to dyspnea, hypoxia. And dyspnea and hyperventilation are prominent, so that until very late in the disease, gas exchange is adequate and blood gas values are relatively normal. Because of prominent dyspnea and adequate oxygenation of the hemoglobin, the patients are sometimes called pink puffers. On the other extreme are patients with emphysema who also have pronounced chronic bronchitis. As we said, emphysema and chronic bronchitis are usually seen in the same patient, and we call them COPD. Chronic bronchitis and a history of recurrent infection with a pleural sputum. They usually have less prominent dyspnea and respiratory drive, so they retain carbon dioxide and become hypoxic and are often cyanotic. Patients with this clinical picture are sometimes called blue bloaters because of the cyanosis and their low drive for breathing. So you see blue bloaters versus pink puffers. In all patients, secondary pulmonary hypertension develop gradually. So if the parenchyma is affected and oxygenation is not taking place, there will be development of pulmonary hypertension. So the pulmonary hypertension will arise from hypoxia-induced pulmonary vascular spasm or loss of pulmonary capillary surface area from alveolar destruction. These patients may relate to pulmonary failure with respiratory acidosis, hypoxia, and coma, or right-sided heart failure, which we call cor pulmonale. So if the heart is failing due to reasons occurring in the lung, we call that cor pulmonale. The lesion is found in the lungs. So right-sided heart failure may kill these patients. The other disease found in this group is chronic bronchitis. Is defined on clinical grounds. It is defined when there is a persistent cough with sputum production for at least 3 consecutive months, consecutive years, in the absence of any other identifiable cause, like if there is no infection or other causes. If a person is coughing with production of sputum from mascaram to Bedar this year, and if that happens in the next year, welcome to Casas, you define or you label that person as having chronic bronchitis, ruling out all other causes. Chronic bronchitis is common among cigarette smokers and urban dwellers in smoke-ridden cities like Addis. Most patients have simple chronic bronchitis, and the productive cough raises mucoid sputum, but airflow is not obstructed. The subpopulation of bronchitis patients develop chronic airflow obstructions as measured by pulmonary function tests usually associated with emphysema. They are said to have chronic obstructive bronchitis also. We label them as COPD. Some patients with chronic bronchitis may demonstrate a hyper-responsive airway and intermittent episodes of asthma, and this condition is termed as chronic asthmatic bronchitis, which is often difficult to distinguish from the regular atopic asthma. Chronic bronchitis, although the single most important causative factor is cigarette smoking, other air pollutants such as sulfur dioxide and nitrogen oxide may contribute. So hazards exposed by different mechanisms may lead to the formation of. The irritants induce hypersecretion of the bronchial mucous glands, cause hypertrophy of mucous glands, and lead to metaplastic formation of mucin secreting goblet cells in the surface epithelium of the bronchi. So there will be excess production of mucus, which is a problem in these patients. In addition, they cause inflammation with infiltration of CD8 T lymphocytes, macrophages, and neutrophils. As chronic bronchitis persists, there is also marked increase in goblet cell of small airways, downwards bronchioles and small bronchi, leading to excessive mucin production that contribute to airway obstruction and even may lead to atelectasis. Whereas the defining feature of chronic bronchitis, mucus hypertension, is primarily a reflection of large bronchial involvement, the morphologic base of airflow obstruction is in chronic bronchitis is more peripheral and results from one, inflammation, fibrosis, and resultant narrowing of bronchi, especially occurring in the small airways, and coexisting emphysema. Microbial infection is often present but plays a secondary role, chiefly by maintaining the inflammation and exacerbating the symptoms. So, if the patient have bronchitis and emphysema, both may be exacerbated by the presence of infection resulting in inflammation and inflammation releasing cytokines and proteases and the like. So, bronchial and bronchial injury is to reversible obstruction in the bronchioli and small bronchi. If there is continued and repeated injury, there will be chronic bronchitis, and destruction of alveolar wall may follow, leading to chronic bronchitis. And same is true with emphysema. In general, both diseases could occur in a person called COPD. Morphologically, grossly, the mucosal lining of the larger airway is usually hyperemic and swollen by edema fluid. It is often covered by a layer of mucus or mucopurulent secretions, and the smaller bronchi and bronchioles may also be filled with similar secretions. Histologically, the diagnostic feature of chronic bronchitis in the trachea and the large bronchi is enlargement of mucus secreting glands. So you see hyperplastic, large mucus secreting glands, and the magnitude of the increase in size is associated by assessed by the ratio of the thickness of the submucosal gland layer to that of the bronchial wall thickness. We call that the Reid index. The normal is less than 0.4, but in case of chronic bronchitis, it will be increased as the size of the mucosal gland is to increase. Here you see this is a respiratory epithelium, and you see this hyperplastic mucus secreting gland with a large area of the bronchial submucosa. Squamous metaplasia frequently develops, followed by dysplastic changes in the lining epithelial cell and sequence of events that may lead to evolution of bronchogenic carcinoma. So the normal metaplasia malignancy sequence may occur, especially if the irritant or if the instigating factor has not been addressed, especially if there is smoking and the person is doing that. Risk of developing bronchogenic carcinoma could occur. A variable density of inflammatory cells, largely mononuclear but sometimes admixed with acute inflammatory cells, is frequently present in the bronchial mucosa. Chronic bronchiolitis is when it occurs in the smaller airways, not the larger one. It is characterized by goblet cell metaplasia, normally the number of goblet cells in the small and peripheral airways. Inflammation, fibrosis in the wall, and smooth muscle hyperplasia is also present. So if it occurs in the distal smaller airways, we call it chronic bronchiolitis, and when it occurs in the upper bronchi, we call it chronic bronchitis. So besides the in the smaller one, you don't find goblet cells, so you may find this intense chronic inflammatory cells as well as these congested vessels, and you see edema here and there. So this makes the wall thicker. Clinically, the cardinal symptom of chronic bronchitis is a persistent cough productive of sputum. And as we said, the diagnosis is clinical. Some patients develop significant COPD with the outflow obstruction. This is accompanied by hypercapnia, increased carbon monoxide, and in severe cases, cyanosis. And differentiation of this form of COPD from that caused by emphysema can be made in the classic case, but many patients have those conditions. So most of these conditions, what we have discussed so far, you find them overlapping in a single patient. So one may have a predominant emphysematous manifestation or emphysematous pathophysiology, or one may have a chronic bronchitis predominant, but most of the patients have a combination of diseases. With progression, chronic bronchitis is complicated by pulmonary hypertension and cardiac failure, recurrent infections, and respiratory failure are constant threats for these patients. So usually we find the chronic bronchitis as well as emphysema in patients concomitantly, and finding pure emphysema or pure chronic bronchitis is rare. The other obstructive airway disease which is very important is chronic asthma. If you have any questions, እንዳልኳችሁ በቮይስ ጠይቁኝ። እሺ እዚህ ጋር ኮሜንቶቻችሁ ላይ ይችላል። አሁን የተነጋገርነው ግልጽ ነው? Thank you, Rash. So asthma is a chronic inflammatory disorder. Probably you have talked about asthma when you were talking about your immunology lectures, when you were talking about hypersensitivity reactions and all. Chronic inflammatory disorder of the airway that causes recurrent episodes of wheezing, breathlessness, chest tightness, and cough, particularly at night and in early morning. The symptoms are usually associated with variable bronchoconstriction that is partly reversible either spontaneously or with treatment. So depending on the degree of manifestation and the degree of instigating factor, you may have to intervene medically, or sometimes when you remove the patients from the noxious stimuli, they may spontaneously resolve. It is thought that inflammation causes an increase in airway responsiveness leading to bronchospasm to a variety of stimuli. It is common disease affecting up to 7% of patients and even higher number of children, but usually asthma occurring in children resolves in their teenage or adulthood. Asthma is classified into two major categories based on the presence or absence of an underlying immune disorder. Could be extrinsic or intrinsic asthma. The extrinsic asthma is the asthmatic episode is typically initiated by a type 1 hypersensitivity reaction induced by exposure to an extrinsic agent. Could be a pollen, it could be some sort of smoke. Three types of extrinsic asthma are recognized: atopic asthma, occupational asthma, and allergic bronchopulmonary aspergillosis. The third one is a bronchial colonization with the fungus called Aspergillus organism, followed by development of immunoglobulin E antibodies for this particular species. The other is intrinsic asthma. The triggering mechanisms are non-immune, and in this form, a number of stimuli that have little or no effect on normal subjects can trigger bronchospasm, and such factors include aspirin, pulmonary infections. Sometimes, if you notice, people who have infection will have obstructive asthma-like symptoms triggered by that simple cold, common cold, and the like, especially those caused by viruses, cold weather, psychological stress, exercise, and inhaled irritants such as ozone and sulfur dioxide may trigger this reaction. There is usually no personal or family history of allergic manifestations, and serum IgE levels are usually normal in these patients, and these patients are safe to have an asthmatic diathesis. The pathogenesis of asthma, the major etiology factor of asthma are genetic predisposition to type 1 hypersensitivity acute and chronic airway inflammation, and bronchial hyperresponsiveness. So most patients have family history of asthma. The inflammation involves many cell types, eosinophils, mast cells, macrophages, T cells, neutrophils, and epithelial cells, and inflammatory mediators say to play an important role in the uh, development of asthma. Type 2 helper cells are prominent components of bronchial inflammation, and they secrete interleukins that stimulate B cells to produce immunoglobulin E. So imbalance of the type 1 and type 2 T cells may be key to asthma attacks. In atopic asthma, one variant of extrinsic asthma. Atopic asthma is the most common type of asthma. Its onset is usually in the first 2 decades of life, and it is commonly associated with other allergic manifestations in the patient as well as in other family members. Certain IgE levels are usually elevated, as is the blood eosinophil count. This form of asthma is believed to be driven by the helper to subtype CD4 T cells. It commences with initial sensitization to inhaled antigen. So let's say a person has inhaled some allergen, so that allergen will be presented to T cells, and this will T helper to cells release cytokine specifically interleukin 4, 5, and 13, which favors the synthesis of IgE. Growth of mast cell will be also encouraged by these interleukins, and growth and activation of eosinophils will occur. And there will be binding of this IgE to mast cell. And whenever this trigger or whenever this allergen comes into contact with that patient or person again, it will directly be integrated with IgE, and the IgE will trigger the mast cells to degranulate, and the eosinophils to degranulate, and all the allergic reactions will take place. So attack of atopic asthma often demonstrate two phases: an early phase beginning 30 to 60 minutes after inhalation of antigen, and then remitting, followed by 4 to 8 hours later by more protracted late phase. Early phase mediators include leukotrienes, extremely potent mediators that cause prolonged bronchoconstriction, increase vascular permeability, and increase mucin secretion. Prostaglandins, which elicit bronchoconstriction and vasodilatation. Histamine causes bronchospasm and increased vascular permeability, and platelet activating factors causing aggregation of platelets and a release of histamine from their granules. These initial reactions are followed by the late or cellular phase, which is dominated by additional recruitment of leukocytes like basophils, neutrophils, eosinophils, and this results in tissue damage and airway constriction. So the mast cell mediators responsible for the recruitment of inflammatory cells include eosinophils, neutrophils, chemoattracting factors like leukotriene B4, recruit and activate eosinophils and neutrophils, interleukin 4 and 5, augment the T helper to response of CD4 T cells by increasing IgE synthesis and eosinophil chemotaxis and proliferation. So all in all, this all leads to degranulation mast cell and this acute attack. So you see this epithelial, this formated. You see these are epithelial cells here and there. form mass spirals. Xenophils and charcoal collection of crystals bodies are also present. You see these crystals from eosinophil formation. Other histologic findings include thickening of the basement membrane of the bronchial epithelium, edema, inflammatory infiltrates with prominence of eosinophils and mast cells, and increase in size of the mucosal glands, hypertrophy of the bronchial wall muscle. So you see the normal, the epithelium, submucosa, the glands, and the cartilage. In bronchial asthma, you see eosinophil mucus, thick layer of mucus, gallbladder cells will be hyperplastic. The submucosa will be full of inflammatory infiltrates and edema will form, and the glands will be also hyperplastic. Will be thickened and contracted. Microscopically, you see this thick mucus layer. You see the epithelial layer is almost being damaged. This is a thin layer of epithelium here. This is mucus, and you see the extreme inflammatory infiltrates and edema. Closer look of the inflammatory mediators. You see these eosinophils, which are binucleated and have this bright orange cytoplasm. So the inflammatory mediators usually you see are eosinophils. Clinical course: the classic asthmatic attack is characterized by severe dyspnea with wheezing lasting several hours, followed by prolonged cough. In the usual cases, attack lasts from 1 to several hours and subside either spontaneously or with therapy, usually bronchodilators and corticosteroids, and intervals between attacks are characteristically free from respiratory difficulties. Occasionally, a severe paroxysm occurs that does not respond to therapy and persists for days and even weeks. We call that status asthmaticus. And when ventilatory function can be severely impaired in these patients and may cause severe cyanosis and even death. So this is another airway disease which causes obstruction, hence we call that obstructive airway disease. The other obstructive airway disease you may encounter, not as much as asthma or COPDs, is bronchiectasis. Ectasis means dilatation, and it's like an emphysema, but is occurring in the bronchus. So it is a disease characterized by permanent dilatation of the bronchi and bronchioles caused by destruction of the muscle and elastic tissue resulting from or associated with chronic necrotizing infections. It is not a primary disease, but rather is secondary to persisting infection or obstruction caused by a variety of conditions. And it is manifested clinically by cough, fever, because there is usually underlying infectious causes and the expectoration of copious amount of foul-smelling purulent sputum. And that's most of the time it is caused by secondary infectious conditions. These conditions that most commonly predispose to bronchitis include bronchial obstruction, like common cause including tumors, foreign bodies, and occasionally impaction of mucus. Under this condition, the bronchiectasis is localized to the obstructed lung segment, and bronchiectasis can also complicate atopic asthma and chronic bronchitis as mucus can plug and result. Congenital or hereditary condition like cystic fibrosis with widespread severe bronchiectasis results from obstruction and infection caused by the secretion of abnormally viscid mucus. This is an important and serious condition. Cartagena syndrome, an autosomal recessive disorder, is frequently associated with bronchiectasis and with sterility in male. Structural abnormalities of the cilia impair mucociliary clearance in the airway, leading to persistent infection and reduce the mobility of spermatozoa in the male reproductive organ. Necrotizing or suppurative pneumonia, particularly with virulent organisms such as Staphylococcus aureus or Klebsiella, may predispose to bronchiectasis. There are two processes which are critical which are intertwined in the pathogens of bronchiectasis. First, there must be obstruction, then there is chronic persistent infection. Either of these two processes may come first. Either the infection may result upon obstruction, or the obstruction may lead to chronic persistent infection. So normal clearance mechanisms are hampered by obstruction, so secondary infection soon follows. Conversely, chronic infection in time causes damage to the bronchial wall, leading to weakening and dilation. Morphology. Bronchoectatic involvement of the lung usually affects the lower lobe bilaterally, particularly those air passage that are most vertical. When tumors or aspiration of foreign body leads to bronchiectasis, involvement may be shared, sharply localized to the single segment of lung. These airways may be dilated to as much as 4 times their usual diameter. So you see, these are airways which are dilated much more than they should be. You can't even recognize them here and there. Are the airways which are dilated. Probably there have been an infection. You see this pleural exudate as well. You see marked dilatation of the airways. Histologically, in the full-blown active case, an intense acute and chronic inflammatory exudate within the wall of the bronchi and bronchioles, and the desquamation of lining epithelium causes extensive areas of ulceration. You see ulcerated epithelium, you see the epithelium has been sloughed off, and you see this dense chronic inflammatory area. Fibrosis of the bronchial and bronchiolar wall and peribronchiolar fibrosis develop in more chronic cases. In some instances, the necrosis destroys the bronchial or bronchiolar wall and forms lung abscess. So collection of gas in the lung may occur due to bronchiectasis. In the usual case, mixed flora can be cultured from the involved bronchi, including staph, strep, pneumococcal, enteric organisms, anaerobics, and particularly in children, Haemophilus influenza and Pseudomonas aeruginosa can be cultured. In the clinical course in these patients, the clinical manifestations consist of severe persistent cough with expectoration of mucopurulence, sometimes fetid sputum. The sputum may contain flakes of blood. Frank hemoptysis can occur. Symptoms are often episodic and are precipitated by upper respiratory tract infections or the introduction of new pathogenic agents. Clubbing of the fingers may develop due to chronic hypoxia of these patients. In cases of severe widespread bronchiectasis, significant obstructive ventilator defects develop with hypoxemia, hypercapnia, pulmonary hypertension, and rarely pulmonary could occur. Metastatic brain abscesses. So if there is abscess cavity and if this access the blood and disseminates in patients, sepsis could occur, or metastatic brain abscesses and reactive amyloidosis are other less frequent complications of bronchiectasis. So far we have seen obstructive airway diseases, namely the COPDs, which are emphysema and chronic bronchitis, asthma, and bronchiectasis. So these are all obstructive airway diseases. Some may involve the larger airway, some may involve the smaller airway, even to the alveolar ducts. So those were chronic obstructive COPDs or obstructive airway diseases. The other ones are restrictive, or in other terms, infiltrative, using the disease, or we prefer the term restrictive lung disease. So these are heterogeneous groups of disorders characterized predominantly by diffuse and usually chronic involvement of the pulmonary connective tissue, principally in the interstitium of the alveolar wall. So restrictive lung diseases are characterized by reduced compliance, meaning the elastic nature of the lung has been lost. So more pressure is required to expand the lung because they are stiff hardened due to different disease processes, and hence the elasticity of the lung has been restricted. Patients have dyspnea, tachypnea, and eventually cyanosis without obstructive symptoms. The airways are fine, so obstructive symptoms will not occur, and eventually secondary pulmonary hypertension and right-sided failure with cor pulmonale may result in these patients. In advanced stages, it results in scarring and gross destruction of the lung, known as end-stage lung or honeycomb lung. You see honeycomb-like lung. Somehow it resembles emphysema, but here the spaces are widened because of the fibrosis, the intervening fibrosis of the interstitium of the lung parenchyma. Conditions associated with diffuse infiltrative disease or the restrictive pulmonary disease are environmental diseases, account 25%, sarcoidosis, 20%, idiopathic pulmonary fibrosis, and cholangiovalvular diseases are important causes for restrictive lung diseases. So the pathogenesis is the earliest manifestation of interstitial disease is alveolitis, and this accumulation of leukocytes distort these alveolar structures, and it results in release of mediators that can injure the parenchymal cells and stimulate fibrosis. So the inflammation of the alveolar, because they are intimately associated with the interstitium, there will be inflammatory cells in the interstitium. So whenever there is chronic inflammation due to some reason, there will be proliferation of fibroblasts. These fibroblasts deposit collagen, leading to scar formation. So the accumulation of leukocytes distorts alveolar structure and is a result of mediators that can injure parenchymal cells and stimulate fibrosis. This gives rise to an end-stage fibrotic lung, in which the alveoli are replaced by cystic space separated by thick bands of connective tissue. So you see these are alveolar spaces, but what's different is here in the interstitium you see bands of collagen or scar-like tissue. The stimuli for alveolitis include oxygen-free radicals and some chemicals which are directly toxic to the endothelial and epithelial cell and results in the recruitment and activation of inflammatory cells. So lung injury due to inhaled agents or dust, blood-borne toxins and the like, they activate macrophages. The activated macrophages include neutrophil, oxidants, proteases will be reduced, injury to type 1 pneumocytes, and fibrogenic and chemotactic agents will be reduced by this macrophage. Fibrogenic and chemotactic hypertrophy and hyperplasia of type 2 pneumocytes, and fibroblastic proliferation occurs. So, when we come to important causes of this restrictive lung disease, we say one category is environmental, and from the environmental one, the most important one is what we call pneumoconiosis. So pneumoconiosis is non-neoplastic lung reaction to inhalation of mineral dust, specifically coal dust, silica, or asbestos. So depending on the agent that is inhaled and deposits in the lung and causing the restriction. The different terminologies will arise. So mineral dust is encountered in workplaces as well as organic like cotton, mold, and inorganic particulates and chemical fumes and vapors may cause what we call pneumoconiosis. Generally, the reaction of the lung to mineral dust depends on many variables, including the size, the shape, the solubility, and reactivity of the particle. For example, that are 1 to 5 micrometers, particles which are 1 to 5 micrometers are the most dangerous because they get lodged at the bifurcation of the distal airways. Larger particles will be entrapped by the mucus and they will be expectorated with the mucus. The smaller particles are dangerous because they can access the distal airways. Most inhaled dust is entrapped in the mucus blanket and rapidly removed from the lung by ciliary movement. However, some of the particles become impacted at the alveolar duct bifurcation, where macrophages accumulate and endocytosis in the trapped particulate occurs. And the pulmonary alveolar macrophage is a key cellular element in the initiation and perpetration of lung injury and fibrosis. The most reactive particle trigger the macrophages to release a number of products that mediate an inflammatory response plus proliferation in collagen deposition, hence resulting in fibrosis. Some of the inhaled particles may reach the lymphatics either by direct drainage or within migrating macrophages and thereby initiate an immune response to components of the particulate and or to self-proteins that are modified by the particles, and this they leads to an amplification and extension of the local reaction to adjacent tissue. Tobacco smoking worsens the effect of all inhaled mineral dusts, more so with asbestosis than with any other particles. So, one form of pneumoconiosis is co-workers pneumoconiosis. አላችሁ አይደለም? አላችሁ? ከኢትዮጵያ አለን ብሏል። ሁላችሁም ተነስታችሁ አንዴ ተንጠራሩ። ብትንጠራሩ አሁን በቃ ቡና እንደጋበዝኳችሁ ይቆጠራል። Are you understanding the lecture? ግልጽ ነው? አንደርስታንድ እያደረጋችሁ ነው? Thank you for telling me when you do your dance. Okay, so let's continue. So co-workers pneumoconiosis, the spectrum of lung findings in co-workers is wide. This was very important because coal mining was very much utilized in previous times in Europe and many countries. Coal mine was used so much for the laborers. Mines, working in mines was very much the case. So people used to work in coal mines, asbestos mines, and then many factories. So it was very important then. Still, there are a significant amount of cases you see. So the spectrum of lung findings in coal workers is wide, ranging from asymptomatic anthracosis, meaning dark staining of the parenchyma of the lung. When we say anthracosis, it's the dark pigmentation of the parenchyma, in which pigment accumulates without a perceptible cellular reaction to simple coal workers pneumoconiosis, which is accumulation of macrophages occur with little to no pulmonary dysfunction, to complicated coal workers pneumoconiosis with progressive massive fibrosis, in which fibrosis is extensive and lung function is compromised. So it could be asymptomatic anthracosis, just pigmentation. It could be simple cold workers pneumoconiosis with minimal effect, or it could be complicated cold workers pneumoconiosis with progressive massive fibrosis. Morphologically, pulmonary anthracosis is most common cold-induced pulmonary lesion in coal miners, and is also commonly seen in all urban dwellers and tobacco smokers because our environment is saturated with the smoke fumes coming from the industries and the cars. Some degree of anthracosis will be found in urban dwellers. Inhaled carbon pigment is engulfed by alveolar or interstitial macrophage, which then accumulates in the connective tissue along the lymphatics, including the pleural lymphatics or lymph nodes. So you see dark staining of the parenchyma of the lung because of anthracosis, and histologically you see macrophages with dark pigmentation containing the coal. As in simple cold workers pneumoconiosis, this is characterized by coal macules and a somewhat larger coal nodule. And the coal macule consists of dust-laden macrophages. In addition, the nodules contain small amount of delicate networks of collagen fibers, forming simple nodules. The most important is complicated cold workers pneumoconiosis or progressive fibrosis. Massive fibrosis occurs on the background of simple cold workers pneumoconiosis by coalescence of these coal nodules, and generally requires many years to develop. It accumulates through time into this complicated cold workers pneumoconiosis, really resulting in restrictive pulmonary disease. So it is characterized by intensely blackened scars larger than 2 centimeters, sometimes up to 10 centimeters in greater diameter, and they are usually multiple. And microscopically, the lesion consists of dense collagen and pigment. Wherever there is collagen, there is fibrosis, and wherever there is fibrosis in an organ, it means there is a restriction of function. So you see this dark, intensely fibrotic, shrunken lung of complicated cold workers pneumoconiosis. Histologically, you see these bundles of collagen areas, and the unique thing is it's dark. It's the collagen is normally a pink material when viewed under hematoxylin eosine tissue, but here you see this area, it's a normal looking collagen, but here there is intense coal accumulated in the active fiber of collagen. The other environmental restrictive disease is silicosis. As the name implies, this one is the deposition of silicon. Silicosis is currently the most prevalent chronic occupational disease in the world, and it is caused by inhalation of crystalline silica, mostly in a occupational setting, because you don't see coal mines here and there anymore, and currently the industry of silica production is higher. These days you may encounter silicosis more than cold workers pneumoconiosis. It is a slowly progressive nodular fibrosing pneumoconiosis, and silica occurs in both crystal and amorphous forms, but the crystalline form, which is quartz, like quartz, are by far the most toxic and fibrogenic of them all. After inhalation, the particle interacts with epithelial cell and macrophages, and the ingested silica particles cause activation and release of mediators by pulmonary macrophages, inducing interleukins, tumor necrosis factor, fibronectin, lipid mediators. So every inflammatory mediators will be released, and fibrogenic cytokines, most importantly, leading to fibrosis. Morphologically, silicotic nodules are characterized grossly in their early stage by thin, barely palpable, discrete, pale to blackened if there is a coal involvement also nodules in the upper zone of the lung. And microscopically, the silicotic nodules demonstrate concentrically arranged hyalinized collagen fibers surrounding an amorphous center. So you see this concentrically arranged fibroblasts and collagen, and centrally you see this pinkish amorphous material. Examination of the nodules by polarized microscopy, a microscope that will help you see foreign materials, which reveals weakly birefringent silica particles, primarily in the center of the nodule, like this. When you see it through a polarized microscopy, you see the silica as this bright content in the tissue. So this is silica as viewed by polarized microscopy. As the disease progresses, the individual nodules may coalesce into hard collagenous scar with eventual progression to massive fibrosis, just like the co-workers pneumoconiosis, and the intervening lung parenchyma may be compressed or overexpanded, and a honeycomb pattern may develop like that of co-workers. Silicosis is associated with an increased susceptibility to tuberculosis, and it is postulated that silicosis results in a depression of cell-mediated immunity, and crystalline silica may inhibit the ability of pulmonary macrophages to kill phagocytized mycobacteria. So because they depress cell-mediated immunity, patients are prone to develop tuberculosis, or with reactivation of primary infected TB may occur. The other group of restrictive lung diseases encompass asbestosis and asbestos-related diseases. Occupational exposure to asbestosis is linked to parenchymal interstitial fibrosis or asbestosis, localized fibrous plaques, or rarely diffuse fibrosis in the pleura, pleural effusion, bronchogenic carcinoma, malignant pleural and peritoneal mesotheliomas, and laryngeal carcinoma. So asbestos, there used to be a large work-related exposure to asbestos some time ago, and patients who or people who were working on those fields, most of them developed malignancies, cancers, and still some industries pay date to those patients for exposing them to this carcinogenic material to date. So the risk of bronchogenic carcinoma is increased about five-fold for asbestos workers, and the relative risk for mesotheliomas normally very rare tumors, normally are very rare tumors. Currently, is more than 1,000-fold greater. So it is highly carcinogenic. Highly bronchogenic carcinomas and mesotheliomas occur. Mesothelioma is in general a rare malignancy, and usually it is if it occurs, it is usually associated with the exposure of asbestos. Otherwise, without exposure of asbestos, you normally don't see mesothelioma in your clinical practice. Concomitant cigarette smoking greatly increases the risk of bronchogenic carcinoma, but not that of mesothelioma. So you see this component of the asbestos engulfed by macrophages. Microscopically, you see this tubular-like structure. So you may find fibrosis, highly fibrogenic, occupational disease. So from the restrictive lung diseases caused by environmental factors, we have covered coal, silicon, and asbestosis. The other restrictive lung disease causing disease process is sarcoidosis, which is categorized under granulomatous inflammation. So sarcoidosis is a multi-system disease of unknown etiology characterized by a non-caseating granuloma in many tissues and organs. So it's not limited to the lung, but non-caseating granulomatous inflammation may occur anywhere in the body. If it's a caseating granulomatous inflammation, your immediate diagnosis will be tuberculosis. But in sarcoidosis, you don't see caseous necrosis and you see non-caseating granuloma. The multisystemic involvement of sarcoidosis can be present in bilateral chiral lymphadenopathy or lung involvement or both. So visible on chest X radiography is the major presenting manifestation in most cases in lung consolidation with hilar lymphadenopathy is a presenting radiologic finding. Eye and skin involvement each occur in about 25% of cases and may occasionally be the presenting features of sarcoidosis. The etiology is several lines of evidence suggest that it is a disease of disordered immune regulation. In general, predisposed individuals exposed to certain environmental agents. Finally, several antigens have been proposed as an inciting agent for sarcoidosis, like virus, mycobacteria, borrelia, or pollen. But thus far, there is no unequivocal evidence to suggest that sarcoidosis is caused by an infectious agent. So rather, it's an immunologic reaction. Morphologically, the histopathologic sine qua is a presence of non-caseating epithelioid granuloma, irrespective of the organ involved. This is a discrete, compact collagen of epithelioids, the collection of epithelioid cells rimmed by an outer zone of large CD40 cells. The epithelioid cells are derived from macrophages and are characterized by abundant eosinophilic cytoplasm and vesicular nuclei. Multinucleated giant cells formed by fusion of macrophages may be seen. A thin layer of laminated fibroblasts is present peripherally to the granuloma. So you see epithelioid histiocytes, footprint-like cells encircling the granuloma. These are epithelioid histiocytes with abundant cytoplasm, and these histiocytes may confluent and get together to form this multinucleated giant cell. Peripherally, you see these smaller dark bluish T lymphocytes, and you may even find some fibroblasts here and there. So you don't see caseous necrosis at the center of the granuloma, which is typically the case in tuberculosis. In tuberculosis, you'll find a caseous necrosis in the center of the granuloma. Two other microscopic features which are sometimes seen in the granuloma are Schaumann body, which is a laminated concretions composed of calcium and protein, and the other is asteroid body, which is a stellate inclusion enclosed within the giant cell, and their presence is not required for diagnosis of sarcoidosis. They may also occur in granulomas of other origin. So you see the Schaumann body, a concentric lamination of proteins, and asteroid body may be seen in the giant cells in patients with sarcoidosis. The lungs are involved at some stage of the disease in about 90% of patients. So the person has sarcoidosis, the lung is inevitably involved, and the granulomas predominantly involve the interstitium rather than air spaces, with some tendency to localize in connective tissue around bronchioles and pulmonary venules and in the pleura. In 5 to 50% of patients, the granulomas are eventually replaced by diffuse interstitial fibrosis, resulting in honeycomb lung, which is the end stage of most Restrictive pulmonary diseases. Intrathoracic, hilar, and paratracheal lymph nodes are enlarged in up to 75 to 90% of patients, and the nodes are characteristically painless and have a firm, rubbery texture. Unlike in tuberculosis, lymph nodes in sarcoidosis are non-matted or non-adherent to one another and do not ulcerate. So you see discrete lymphadenopathies in sarcoidosis, while usually in tuberculosis you find matted lymph nodes. The skin lesions in sarcoidosis are encountered in approximately a quarter of patients, and involvement of the eye and the lacrimal glands occur in about 1/5 to 1/2 of patients, and the ocular involvement takes the form of iritis or iridocyclitis, and maybe unilateral or bilateral. These ocular lesions are frequently accompanied by inflammation in the lacrimal gland, which suppresses lacrimation, and we call that Silicosis. So patients with this disease are unable to shed a tear. Unilateral or bilateral enlargement of the parotid or parotitis with painful enlargement of the parotid gland occurs in 10% of individuals with sarcoidosis. Some go on to developing xerostomia or dry mouth because of inability to produce saliva. And combination of this uveiparotid or uveitis and parotitis involvement is designated as Mikulicz syndrome. So you see bilateral parotitis patients, and if you do a fine needle aspiration cytology in this gland, you will find non-caseating granulomatous inflammation. The spleen, the liver, and bone marrow are also other common involved organs, and sometimes there is hypercalcemia and hypercalciuria. This is caused by increased calcium absorption secondary to the production of active vitamin D by the mononuclear phagocytes of the granulomas. Clinically, in many individuals, the disease is entirely asymptomatic. In about 1/3 of symptomatic cases, there is a gradual appearance of respiratory symptoms, shortness of breath, dry cough, or external discomfort, or constitutional signs and symptoms like fever, fatigue, weight loss, or anorexia, sweating may occur. Diagnosis is made based on lung or lymph node biopsies, and the presence of non-caseating granuloma is suggestive of sarcoidosis, but other identifiable causes of granuloma inflammation must be excluded, especially in our setup. You find tuberculosis everywhere, and we should first rule out that the granuloma is not being caused by tuberculosis, as tuberculosis is the commonest cause of granulomatous inflammation in our setup. So excluding that, if you find granulomatous inflammation, you can diagnose sarcoidosis. The remission may be spontaneous or initiated by therapy and are often permanent. This is important to distinguish between tuberculosis and sarcoidosis because both are granulomatous inflammations. One is caseating and the other is non-caseating. But the treatment modalities for both are, for sarcoidosis, you give steroids, which are suppressing the inflammatory process. If in case you misdiagnose a TB patient for sarcoidosis and he gets treated with steroids, you are writing a death sentence for that patient. So getting the diagnosis right in this case is very important, as the diagnostic modality and the treatment modality are so different and opposite. Overall, up to 70% of individuals recover with minimal or manifestations. 20% develop permanent lung dysfunction or visual impairment. Of the remaining up to 50%, most succumb to progressive pulmonary fibrosis and pulmonary and disease. So far, we have seen the restrictive obstructive and restrictive airway disease. Do you have any questions, comments, suggestions? Shall we continue?
ብሬክ እንውሰድ ትንሽ ዶክተር።
እየተሰማኝ ስላልሆነ አንዴ ሶሪ። ምን አልከኝ መርከብ?
ብሬክ ትንሽ ደቂቃ እንውሰድ።
እሺ እሺ፣ ስንት ደቂቃ እንውሰድ? 10 minutes?
እሺ 10 ደቂቃ እንውሰድሽ።
10 ደቂቃ ስትሬች አድርጉና እንመለሳለን።
እሺ
how can we avoid misdiagnosing sarcoidosis from TB? Good question. First, the morphologic diagnoses are different. One is caseating granulomatous inflammation and the other is non-caseating granulomatous inflammation. However, TB may be present without caseation. So you do additional stains. What are the most important stains you know to identify acid-fast bacilli? Is the acid-fast bacilli stain, I don't know, the Ziel-Nielsen stain. So you do additional staining to identify whether mycobacterial tuberculosis is present or not. So in tissues, you can also do that and diagnose whether this is actually TB or sarcoidosis. Clear now? Can you hear me? Group are Hypersensitivity Pneumonitis and Hypersensitivity, as the name implies, it's reactivation to overactivation to some triggers. This hypersensitivity pneumonitis is an immunological mediated inflammatory lung disease that primarily affects the alveoli and is therefore often called allergic alveolitis. So it is below on the lower end of the airway, not in the upper like the asthma. Most often it is an occupational disease that results from heightened sensitivity to inhaled antigens such as small d hay. And unlike bronchial asthma, in which bronchi are the focus of immunologically mediated injury, the damage in hypersensitivity pneumonitis occurs at the level of the alveoli. Hence, it is present as a predominantly restrictive lung disease with a decreased diffusion capacity, lung compliance, and total lung volume decrement. Morphologically, The histology of both acute and the chronic forms of hypersensitivity pneumonitis demonstrates patchy mononuclear cell infiltrates in the pulmonary interstitium and lymphocyte predominant, but plasma cell and epithelial cells are also present. In interstitial non-causating granulomas are present in more than 2/3 of cases, usually in peribronchial location. And in advanced chronic cases, diffuse interstitial fibrosis occurs, and these allergens are the molds and the like, causing granulomatous inflammation, but the granuloma is occurring down in the alveolar septa. So this is an alveolar space, and you see this inflammation. You see multinucleated giant cells here and there, as well as granuloma formation at the distal site of the lung. This entity may present either as an acute reaction with fever, cough, dyspnea, and constitutional complaints 4 to 8 hours after exposure, or as a chronic disease with insidious onset of cough, dyspnea, malaise, and weight loss. If antigenic exposure is terminated after acute attack of the disease, there is a complete resolution of pulmonary symptoms within days, like many allergic reactions. Failure to remove the inciting agent from the environment eventually results in chronic interstitial pulmonary disease, especially dwelling in a house having molds in the wall, especially if there is poor leakage and if the drainage pipe or the roof are leaking. You see these molds forming on the wall. ብዙ ጊዜ ግድግዳ ቤቶች ግድግዳ ላይ ሞይስቸር ያለበት ቦታ ላይ እንደዚህ እንደ ሻጋታ ነገር የሆነ የሚሰራ ነገር አለ. So exposure to that itself may trigger this hypersensitivity pneumonitis, and unless a person is removed from that place or you remove that mold from that house, patient may develop this chronic lesion. So with that, we wind the topic on restrictive pulmonary diseases and continue with pulmonary infections. So pneumonia can be defined as infection of the lung parenchyma, and it can be acute or chronic. So inflammation of the lung is called pneumonitis, and it could occur in acute or chronic forms. Pneumonia can result either it could result whenever these defense mechanisms are impaired or the resistance of the host is lowered. So there are many defense mechanisms in the lung, starting from the cilia, the mucus, the alveolar macrophages, and the like. There are different defense mechanisms in place in the lung. The clearing mechanisms can be interfered by the following factors, like loss or suppression of cough reflex as a result of coma. So whenever we cough or sneeze, we are removing unwanted materials from our system. And this is an important mechanism. In a state where the mental awareness or the mental capacity of the patient have decreased due to different illnesses, the reflex of this cough reflex as well as sneezing reflex is suppressed. So whatever gets access into the airway cannot be cleared by this mechanism. Injury to the mucociliary apparatus, like due to cigarette smoke. It's a noxious stimuli. You're putting smoke where there should be pure air in, and this injures the mucociliary apparatus. If the cilia is damaged, the upward movement of clearing of the mucus with the debris will not happen. Interference with the phagocytic or bactericidal actions of alveolar macrophage by alcohol, cigarette smoking may interfere with this clearing. Pulmonary congestion and edema accumulation of secretions in conditions such as bronchial obstruction, like in bronchiectasis and the like, will hamper this clearing mechanism, predisposing us for pneumonia. One type of pneumonia sometimes predisposed to another. If a person has viral pneumonia, this viral pneumonia may be a factor to develop bacterial pneumonia and the like. So portal of entry for most pneumonias is respiratory tract, but hematogenous seeding can also occur. Pneumonias are classified either by the specific etiologic agent or, if no pathogen can be isolated, by the clinical setting in which the infection occurs. Is it occurring at home? Is it occurring at a hospital? And the like. So classify pneumonia by the setting. And you will let us. So classify pneumonia by the setting in which they arise. Considerably narrows the list of suspected pathogens for administrating empirical antimicrobial therapy. So we know which organisms are common in the living setting or in the home setting, and we know which bacteria are common in the hospital setting and the like. So whenever we associate the etiology with the setting, we can administer targeting those causative agents. So one classification is community-acquired acute pneumonia. Most community-acquired acute pneumonias are bacterial in origin. Commonly, the infection follows viral upper respiratory tract infection, and the onset is usually abrupt, with high fever, shaking, chills, pleuritic chest pain, and productive cough. So symptoms of acute inflammation occurs. Bacterial invasion of lung parenchyma causes the alveoli to be filled with an inflammatory exudate. So acute inflammation resulting with edema is a common finding anywhere. If you find if you have inflammation, you have one of the four cardinal symptoms, which is formation of edema or tumor. So filled with an inflammatory exudate resulting in consolidation or solidification of the lung parenchyma where it is affected. Predisposing conditions include extremes of age, so the most young and the most old are affected. Chronic diseases like the COPDs, congenital or recurrent immunodeficiencies, or absence of spleen, which could help in removing some organisms, may predispose to community-acquired pneumonia. So the agents have believed to cause this community-acquired pneumonia. One is Streptococcus pneumoniae. So S. pneumoniae is the most common cause of community-acquired pneumonia, and the presence of numerous neutrophils containing the typical gram-positive lancet-shaped diplococci supports the diagnosis of pneumococcal pneumonia. So you see this gram-positive diplococcus. Other cause of community-acquired pneumonia: Haemophilus influenzae, Moraxella, Staph, Klebsiella, which is the most frequent cause of gram-negative bacterial pneumonia, Pseudomonas Legionella pneumoniae, all could cause community-acquired pneumonia. Morphologically, bacterial pneumonia has two anatomic and radiographic patterns of distribution. One could be bronchopneumonia, which is a patchy consolidation of the lung, patchy distribution of inflammation that generally involves more than one lobe. This pattern results from an initial infection of the bronchi and bronchioles with extension into the adjacent alveoli. So bronchopneumonia may involve the bronchial segment with the associated lobar parenchyma. Whilst when we say lobar pneumonia, it encompasses the entire lobe of the lung. So bronchopneumonia, the bronchial segment with the associated lung parenchyma. So you see these lesions in the lung with hypoechoic lesions here and there, characterizing lesion going on in the lung. So bronchopneumonia, you see the bronchial walls with associated parenchyma. Basal lobar pneumonia, infection resulting in fibrinous-suppressive consolidation of a large portion of a lobe or of an entire lobe. In a lobar pneumonia, the contiguous air spaces of part or all of the lobe are homogeneously filled with an exudate that can be visualized on radiography as a lobar or segmental consolidation. Strep pneumonia is responsible for more than 90% of lobar pneumonias. So an entire lobe has been involved by an entire hypoechoic area. An entire lobe is being involved by lobar pneumonia. In lobar pneumonia, 4 stages of the inflammatory response have been described. First, there is congestion, followed by red hepatization, then gray hepatization, then resolution. When you say congestion, the lung is heavy, bulky, and red because of acute inflammatory infiltrates and acute inflammation taking place in the lung. It is characterized by the vascular engorgement, intraalveolar fluid with few neutrophils and presence of numerous bacteria. In the stage of red hepatization, it is characterized by massive exudation with red blood cells, neutrophils, and fibrin filling the alveolar spaces. Because grossly the lobes appear red, firm, airless, they look like the liver. So the organ looks like the liver. If a piece of lung at the stage of red hepatization is presented to you, you may even say, oh no, this is the liver, not the lung. So that hence the name red hepatization, liver-like consistency. Red hepatization. So, red hepatization stage, it occurs due to the progressive disintegration of these red cells and the persistence of fibrinopyrin and exudate, giving the grayish-brown appearance. Microscopically, you see exudates of this polymorphonuclear inflammatory cells, edema, and areas of thickened walls. At the stage of resolution, it follows when it follows uncomplicated cases, exudates within the alveolar are enzymatically digested to produce granular semi-fluid debris that is resorbed, ingested by macrophages and coughed up or organized by the fibroblasts going into it. Also, what complications can we expect from a patient having pneumonia? Tissue destruction and necrosis may lead to abscess formation, so lung abscess may occur. Suppurative material may accumulate in the pleural cavity, producing what we call as empyema or pus collecting in the pleural space. Could be one complication of pneumonia. Organization of the intraalveolar exudate may convert areas of the lung into solid fibrous tissue. So if the tissue is the fluid found filling the airway space, the alveolar space is not cleared, and if it organizes, it blocks the alveolar space. So there will be fibrotic tissue visible in the lung. Bacteremia dissemination may lead to sepsis, leading to involvement of bacterial infection at different sites, like the brain, the meninges, leading to meningitis, the joints, arthritis, or the heart could lead to infective endocarditis. So dissemination bacteremia may occur. You see segment of lung with exudative covering. So that the other group is community-acquired atypical pneumonia. So community-acquired pneumonia is the one caused by the commonly known agents, and the other group is pneumonia. The term denotes the moderate amount of sputum, absence of physical clinical findings of consolidation, only moderately elevation of WBC count and lack of alveolar exudate. So the presenting symptoms are not as severe as the usual community. In this case, morphologically, the process may be patchy or it may involve the whole lobe. Bilaterally or unitarily, macroscopically, the affected area are red, blue, and congested. Histologically, the inflammatory reaction is largely confined within the walls of the alveolar. In contrast to bacterial pneumonia, alveolar spaces in atypical pneumonia are remarkably free of cellular exudate, which is in patients better dealt with because it does not put them into respiratory distress. So the alveolar wall is somehow expanded by these inflammatory cells, predominantly UC lymphocytes, but the alveolar space does not have the debris, which is very dangerous in pneumonia. Atypical pneumonia is caused by a variety of organisms, like mycoplasma being the most common. Other etiologies are viruses, including influenza virus, respiratory syncytial virus, adenovirus, rhinovirus, and other organisms. Nearly all of these agents can also cause primarily upper respiratory tract infection, or usually they cause common cold in many patients. The onset is usually that of an acute, non-specific febrile illness characterized by fever, headache, and malaise, and later cough with minimal sputum. Because the edema and exudates are posed in a strategic position to cause an alveolar capillary block, there may be respiratory distress seemingly out of proportion to the physical and radiologic findings. So hence the diagnosis of pneumonia will be given. Nosocomial pneumonia or hospital-acquired pneumonia is the other group of pneumonia where the agent is acquired in the setting of a hospital. So these are defined as pneumonia pulmonary infections acquired in the course of hospital stay. So a patient may visit the hospital for another unrelated diseases and may be admitted, and in the meantime the patient may develop pneumonia. So the inciting agents you suspect in this kind of setting are not those causing pneumonia in the community. So nosocomial infections are common in hospitalized persons with severe underlying diseases, immune suppression, or prolonged antibiotic therapy. Gram-negative hosts like Enterobacteriaceae and Pseudomonas and Staph aureus are the most common isolates in this group. The other group of pneumonia could be aspiration-related pneumonia. So aspiration pneumonia occurs in markedly debilitated patients or those who aspirate gastric contents either while unconscious after a shock or during repeated vomiting. So whenever the food material or gastric content accesses the airway for whatever reason, aspiration pneumonia will occur. So these individuals have abnormal gag and swallowing reflex that facilitates leakage of aspiration of contents of the GI into the lung. So the resultant pneumonia is partly chemical because there is a hydrochloric acid of the gastric content resulting from the extremely irritating effect of the gastric acid, and partly because of bacteria or the oral flora accessing through the aspiration process. Typically, multiple organisms are isolated, aerobes more common than anaerobes. This type of pneumonia is often necrotizing, pursues a fulminant clinical course, and is a frequent cause of death in person predisposed to aspiration. In those who survive, abscess formation is a common complication. So in patients who are unconscious for many reasons, either for stroke, accidents, or shock, if you see, there is to prevent aspiration, they will the tube will be inserted in the stomach. So nasogastric tube will be inserted to prevent the risk of aspiration of contents into the lung. So lung abscess is referred to as a localized area of suppurative necrosis within the pulmonary parenchyma, resulting in the formation of one or more large cavities. The causative organism may be introduced into the lung by any of the following mechanisms: aspiration of infected materials, which is the most frequent cause, as a complication of necrotizing bacterial pneumonias, particularly those caused by Staph aureus, Streptococcus pyogenes, Bacilla, Pseudomonas, and mycotic infections and bronchiectasis may lead to lung abscess. So bronchial obstruction with sequestration of contents leading to proliferation of bacteria may lead to lung abscess, and third complication of septic embolism may occur from this abscess to different parts of the organ. Abscess vary in diameter from a few millimeters to a large cavity, and the localization and number of abscess depends on the mode of the development. Pulmonary abscesses resulting from aspiration of infected material are much more common on the right side because the bronchus is more vertical in the right side than on the left side, and we start single. Septic emboli and abscess arising from hematogenous spread are commonly multiple and may affect any region of the lung. So if the instigating factor is coming from another site of infection via the blood, it doesn't usually be a single entity, and it could lead to multiple cavities of abscess. So you see abscess cavity here. Abscess cavities here and here. Occasionally, abscess ruptures into the pleural cavity and produce bronchopulmonary fistula, and the consequence of which is pneumothorax or empyema or both. Other complications are from embolization of septic material to the brain, giving rise to meningitis or brain abscess. Histologically, there is wherever there is abscess, there is polymorph follicular cells and fibrin, and there is suppuration surrounded by various amount of fibrous scar and mononuclear inflammatory cells like lymphocytes, plasma cells, macrophages, depending on the chronicity of the lesion, may be also seen besides neutrophils. So you see a dense area of neutrophilic abscess. Clinically, the manifestations of a lung abscess include prominent cough that usually yield copious amounts of foul-smelling, purulent, or sanguineous sputum with mixing of blood, occasionally with hemoptysis occur. Spiking fever and malaise are common. Clubbing of fingers, where you lose the angle between the nail and the nail bed when you say clubbing. Weight loss and anemia may also occur in these patients. So this is acute pneumonia, which mandates treatment for patients to avoid complication or long-term effects. The other groups are chronic pneumonias. Chronic pneumonia is most often a localized lesion in an immunocompetent person with or without regional lymph node involvement. There is typically granulomatous inflammation, which may be due to bacteria like TB or fungi, and in the immunocompromised, such as those with debilitating illness or immunosuppressive agents or with HIV infection, there is usually systemic dissemination of the causative organism accompanied by widespread disease. TB is by far the most important entity within the spectrum of chronic pneumonia, with the WHO estimating that TB causes 6% of all deaths worldwide, making it the most common cause of deaths resulting from single infectious agent, and still it is still an important cause of morbidity and mortality in our country as well. The other causes for chronic pneumonia are fungal structures like histoplasma, coccidioidomycosis, and blastomycosis. This dimorphic fungi, which includes Histoplasma capsulatum, Coccidioidomimetis, and Blastomycosis genitidis, present with isolated pulmonary involvement, as commonly seen in infected immunocompetent individuals, or with disseminated disease in immunocompromised patients. The yeast forms are fairly distinctive, which help us in the identification of individual fungi in this tissue sections. Histoplasma is a round oval and small yeast form measuring 2 to 5 micro diameter, while Coccidioido is thick-walled, non-budding, spherule, relatively larger than the others, and it's often filled with small endospores. Blasto is round to oval and larger than Histoplasma, larger than the rest. Histoplasma reproduced by characteristic broad-based budding. So you see here Histoplasma capsulatum, and you see the broad. I'm sorry, this is not. This is Coccido, while you see this broad-based budding, which is a characteristic feature of Histoplasma. Clinical features, clinical manifestations may take the form of acute primary pulmonary infection. The primary pulmonary nodules composed of aggregates of macrophages stuffed with organisms are associated with similar lesions in the regional lymph node. These lesions develop into small granulomas, giant cell, and may develop central necrosis and later fibrosis and calcification. The similarity to primary TB is striking, and differentiation requires identification of the yeast form, best seen with periodic acid shift or silver stain. So you may do, if you are not able to visualize the fungal structure as described, and if the strong suspicion is there, you can do special stain of PAS or silver stain to confirm whether it is fungal or not, and acid-fast stain to confirm if it's TB or not. Because both causes caseating granulomatous inflammation. The clinical symptoms resemble a flu-like syndrome, most often self-limiting in immunocompetent patients. Chronic cavitary pneumonia pulmonary disease is another manifestation in this group. In the vulnerable host, especially, chronic cavitary pulmonary disease develop with a predilection for the upper lobe, resembling the second form of TB. At this stage, cough, hemoptysis, and even dyspnea and chest pain may appear. Disseminated miliary disease occurs in infants or immunocompromised adults, particularly those with HIV. Disseminated disease analogous to miliary TB may also occur in these fungal entities. Under the circumstance, there are no well-formed granulomas. Instead, focal collection of phagocytes stuffed with yeast form are seen within cells of the mononuclear phagocytic system, including the liver, spleen, lymph node, lymphoid tissue of the gastrointestinal tract, and bone marrow. Because immunosuppression, there is ineffective T cell activation. Formation of granuloma will be hampered be it for TB or fungal diseases. So the presence of T cells is important in the formation of granulomatous inflammation, and if there is immunosuppression in that line, mounting a granulomatous inflammation will be difficult and impossible. You see this cavitary lesion in the lung, and if you see, you can find in silver stain fungal structures in the macrophages. You see granulomatous inflammation containing a fungal structure in them. If you are unsure, you can do special stains of PAS or silver stain to confirm your suspicion. Again, granulomatous inflammation, and in this giant cell, you see fungal elements. So in this giant cell, you see multiple fungal elements. A different group of people have different settings for the development of pneumonia. So pneumonia in the immunocompromised host is somehow different from the immunocompetent host. So the appearance of pulmonary infiltrate and sign of infection like fever are some of the most common and serious complications in persons who are immunosuppressed. A wide variety of so-called opportunistic agents, many of which rarely causes infection in normal hosts and immunocompetent hosts, can cause this pneumonia, and often more than one agent is involved. So examples of pulmonary opportunistic pathogens include Pseudomonas, Mycobacterium species, Legionnaires pneumonia, pneumophila, and Listeria monocytogenes. Virus like CMV, herpes viruses, fungi like PCP, pneumocystic candida, aspergillus, cryptococcus neoformans, all are more severe in immunocompromised patients than immunocompetent patients. So, for disease of the vascular origin, revise your lectures on pulmonary embolism in general pathology, and for disease entity tuberculosis, you should refer to your immunologic lectures and your microbiology lectures. So it would be redundant to repeat these topics. Pulmonary hypertension is an important and essential disease process which you will encounter in your practice as physicians. So pulmonary hypertension is defined as when mean pulmonary pressure reaches 1/4 or more of systemic level. So this is how you define it. It can be primary or secondary. The secondary is most frequently encountered. Primary or idiopathic pulmonary hypertension is diagnosed when all known causes of increased pulmonary pressure can be excluded, like diseases occurring in the heart or diseases occurring in the lung causing the pulmonary hypertension. You cannot find any lesions associated with that. You diagnose primary or idiopathic pulmonary hypertension. Of this, the vast majority of cases are sporadic, and only 6% have familial forms with an autosomal dominant mode of inheritance. And the cause for secondary hypertension include chronic obstructive or interstitial lung disease. So all processes that we have discussed so far are able, if left untreated and if they are not managed well, are all able to bring about pulmonary hypertension. So chronic obstructive or interstitial lung disease, which is accompanied by destruction of lung parenchyma and consequent reduction in alveolar capillaries, this causes an increase in pulmonary arterial resistance and secondarily elevated arterial pressure. Recurrent pulmonary embolism, which leads to a reduction in the functional cross-section area of the pulmonary vascular bed, in turn leads to increased vascular resistance. Antecedent heart disease, for example, like valvular stenosis. You have been taking lectures on cardiovascular system. So mitral stenosis, which increases the left atrial pressure, leading to higher pulmonary venous pressure backwards and ultimately pulmonary arterial hypertension. It does this because it has to protect from flooding or from being overwhelmed by the degree of blood being sequestered in the lung. Congenital left to right shunts are another cause of secondary pulmonary hypertension. In states of secondary pulmonary hypertension, endothelial cell dysfunction arises as a consequence of the underlying disorder. So shear and mechanical injury due to increased blood flow on the left to right shunt, or biochemical injuries produced by fibrin in recurrent thromboembolism. Endothelial cell dysfunction reduces production of vasodilator agents like nitric oxide and prostacyclin, which increases synthesis of vasoconstrictive mediators like endothelin. In addition, There is production of growth factors, intermediates, and induce migration and replication of vascular smooth muscle cells and elaboration of extracellular matter, all in all leading to increased pressure in the vessels. Morphologically, vascular alterations in all forms of pulmonary hypertension, like be it primary or secondary, involves the entire arterial tree and includes the main elastic arteries, the medium-sized muscular arteries, and the small arteries and arterioles. In the main elastic arteries, you see atheromas similar to those in systemic atherosclerosis. In the medium-sized muscular arteries, you see proliferation of myointimal cells and smooth muscle cells, causing thickening of the intima and media with narrowing of the lumen. With the narrowing of the lumen, the pressure increases. When the area decreases, the pressure increases. The smaller arteries and arterioles, you see thickening, medial hypertrophy, and reduplication of the internal and external elastic membranes. In these vessels, the wall thickness may exceed the diameter of the lumen, which is sometimes narrow to the point of near obliteration. Clinical course, secondary pulmonary hypertension may develop at any age if there is instigating factor in the heart or the lung. That clinical features reflect the underlying disease. So if the patient have chronic asthma or heart failure and the like, you see that before you diagnose pulmonary hypertension. Respiratory insufficiency and right-sided heart strain will follow. So far, these are the important non-neoplastic conditions occurring in the lung. So there is congenital ones, there is atelectasis, there is obstructive pulmonary lesions, and there is inflammatory lesions like pneumonias, and the lung as a secondary involvement in pulmonary hypertension, especially the primary pulmonary hypertension is a very, very entity. But all the diseases occurring in the lung as well as in the heart will result about pulmonary hypertension. If there is a left-sided heart failure or parenchymal lung disease, all results in pulmonary hypertension. This pulmonary hypertension will put pressure in the right side of the heart as well, leading to right-sided heart failure. The right-sided heart failure is occurring due to the failure of the left side of the heart, which usually occurs, which is usually the case. We just call it the right-sided heart failure. But if the right side of the heart is failing due to conditions occurring in the lung, we call that pulmonary. Do you have any questions with regards to what we have discussed so far? For pulmonary sequestrations who are born with this kind of thing, if it is non-communicating, we can remove. Removing the segment of the sequestrum is the best case scenario. So usually surgical intervention could occur. But if the sequestration are in major areas, it will be difficult, but somehow you can remove the distorted part and help the patient well. Any other questions? Are you understanding the lecture? Am I clear? No, if we are removing the abnormal part, the normal part of the lung will not be affected. Rather, it will be helped if this abnormality may progress and impair the function of the lung, putting pressure on the normal lung, removing it is the best thing you can do for the lung. So removing the abnormal or the fibrous or the sequestered part does not affect the normal lung, rather it will help it. People can survive with even one lung, right? You're welcome. So everything clear so far? We can continue. So the other group of disease, which we probably by the time when you're physicians, will be your bread and butter. When we were physicians, our bread and butter was TB. Everybody told us never to miss TB. Currently, the thing has changed so far that malignancy is predominating the entire health spectrum. So tumors are important factors of morbidity and mortality currently, and by the time you're physicians, those will be your areas to look out for. So tumors in the lung, a variety of benign and malignant tumors arise in the lung. Carcinomas occur in the most 95% of the cases. Bronchial carcinoids, currently termed as neuroendocrine tumors, occur in 5%, and mesenchymal tumors occur. So carcinomas, lung cancer is the leading cause of cancer deaths worldwide, especially in the Westerns. Lung cancer is the leading cause of death in both men and women. Etiology, major risk factors for the development of lung cancer are cigarette smoking, occupational hazards like inhalation of asbestos or other dusty radioactive agents, pulmonary fibrosis, and peripheral lung cancers. Usually adenocarcinoma tend to arise in areas of fibrous scar like old TB, focus, or infarcts. Tobacco smoking has been incriminated not only in lung cancer but most of carcinomas occurring in the human being, like pancreas, GI, larynx, bladder. So most malignancies are incriminated with the use of tobacco. So about 90% of lung carcinomas occur in active smokers or who has stopped recently, compared with non-smokers. Average smokers of cigarette have tenfold greater risk of developing lung cancer. And cessation of smoking for 10 years reduces risk, but never to the control level or to the normal level. Passive smokers are also in somehow risk factor for developing. They are not immune from developing lung cancer. There is progressive increase in the bronchial mucosal associated with smoking, and progressive changes in the bronchial wall. Carcinoma is preceded by squamous metaplasia and subsequently dysplasia. Most lung carcinomas arise from the bronchi close to the hilum. Usually an upper lobe or main bronchus is involved. Small portions of tumor arise in the periphery of the lung substance from alveolar septal cells or terminal bronchioles. These are predominantly adenocarcinomas. Otherwise, the proximal ones usually are, if there is squamous metaplasia, dysplasia, there is squamous cell carcinoma by default. They may form intraluminal masses, invade the bronchial mucosa, or form large bulky masses pushing into the adjacent lung parenchyma. So you see, this is a bronchial carcinoma infiltrating the adjacent lung, even it has reached into the pleural surface of the lung. So this is a very devastating bulky tumor occurring in the lung. The four major histology types of carcinomas of the lung are squamous cell carcinoma, occurring especially in the main bronchus, adenocarcinoma, small cell carcinoma, and large cell carcinoma. So we tend to classify them roughly as small cell and non-small cell carcinoma. So the small cell is separated, while the squamous adenoid and Bronchial carcinoma are categorized as non-small cell carcinomas. So squamous cell carcinoma, this is the type most closely associated with cigarette smoking, and the tumor are almost always hilar, squamous cell carcinoma or proximal. Squamous cell carcinomas are often preceded for many years by squamous metaplasia or dysplasia in the bronchial epithelium, which then transforms to carcinoma in situ, a phase that may last for several years. And this tumor tend to metastasize locally to hilar lymph nodes. Distant metastases are a later features in squamous cell carcinoma of the lung. So you see this proximal, just at the bifurcation of the bronchi, you see this solid, dense, irregularly bordered, infiltrative margins of tumor. You see this is a bronchial lining, and you see this infiltrative whitish tan mass enveloping majority of the lung. You see this irregular, infiltrative, solid mass. So grossly, you can characterize that it is malignant because it has infiltrative borders. It's not well circumscribed. Microscopically, wherever you see squamous cell carcinoma, the morphology is similar. You see malignant squamous cells with different degree of differentiation. So here you see squamous cells with keratinization, so they are somehow differentiating. Here at this area, you don't see keratinization, so somehow this is a moderately differentiated squamous cell carcinoma. If it's a squamous cell carcinoma in the cervix, you see similar. If it's in the esophagus, you see similar. So morphologically, under the microscope, you see similar things, but they can occur at different sites. Small cell carcinoma or old cell carcinoma usually arise in hilar bronchus. Again, they metastasize very early. These are aggressive tumors occurring in the lung. These tumors are derived from neuroendocrine cells of the lung, and they express polypeptide hormones that may result in paraneoplastic syndromes. And the histology is of highly cellular tumor composed of small cells with hyperchromatic nuclei. So you see this patchy, solid, whitish, irregularly occurring solid areas. Macroscopically, you see this hyperchromatic, meaning the nucleus has been stained more than it should. We call that hyperchromatic. So the chromatin of the nucleus has been stained by the hematoxylin stain, and it gives you this bluish appearance and characteristics of small cell carcinoma. So adenocarcinoma, these are usually peripheral, occurring in the subpleural area. There is significant association with diffuse pulmonary fibrosis and honeycomb lungs. So in stage lung disease may be risk factor for adenocarcinoma. Adenocarcinomas are the most common type of lung cancer in women and non-smokers, and the putative precursor of peripheral adenocarcinoma has been described as atypical adenomatous hyperplasia. So the putative precursor for squamous cell carcinoma is squamous metaplasia and dysplasia, especially dysplasia, while for adenocarcinoma it's atypical adenomatous hyperplasia. So you see it is found, unlike the squamous cell carcinoma, at the periphery, at the subpleural area. And microscopically, you see malignant cell forming glands or ducts, hence adenocarcinoma. So whenever they recapitulate epithelium forming a glandular structure, we call it carcinoma. Wherever you find this, you diagnose adenocarcinoma. Bronchoalveolar carcinoma are included as subtype of adenocarcinomas in the current WHO classification of lung, but they involve peripheral part of the lung, either as a single nodule or more often as multiple diffuse nodules that may coalesce to produce pneumonia-like consolidation. The key feature for bronchoalveolar carcinoma is their growth along pre-existing structures and the preservation of alveolar architecture. So the tumor cells creep along the alveolar wall and infiltrate. These neoplasms in general have a better prognosis than the most other primary lung carcinoma, like the small cell is the worst, and adenomas are the second worst. So it's difficult to see and grossly because they infiltrate along the septa of the parenchyma of the alveolar like this. So this is a normal alveolar structure. Here you see the single cell layer, it's fully outlined alveolar space. Here you see the tumor infiltrating the same line of alveolar to disseminate. So this we call bronchoalveolar carcinoma. It's a type of adenocarcinoma, but the dispersion or involvement is characteristic. It is categorized as bronchoalveolar carcinoma. The others are large cell undifferentiated carcinomas, usually centrally located. These are highly aggressive and destructive lesions with necrosis and hemorrhage. Histologically, there is gross nuclear pleomorphism with numerous bizarre mitosis. Firstly, you might not know whether this is small cell, large cell by just looking at it. So combination of patterns may occur. Significant majority of bronchogenic carcinomas reveal more than one line of differentiation. For all of these neoplasms, successive chains of lymph nodes are involved with nodes about the carina, in the mediastinum, in the neck, scalens nodes, and clavicular region, and sooner or later distant metastasis will occur. Involvement of the left supraclavicular node, or what we call virtuous node, is particularly characteristic and sometimes called attention to an occult primary tumor. So patients may just come to you with left supraclavicular lymph node enlargement, and when you send these patients for investigation of fine needle aspiration cytology, if the report comes as secondary infiltrates of adenocarcinoma, you should try to look for the primary in the lung or other tissues. They may compress or infiltrate the superior vena cava to cause either venous congestion or the full-blown vena cava syndrome may occur. Apical neoplasms, those located in the apex of the lung, may invade the bronchial or cervical sympathetic plexus to cause severe pain in the distribution of the ulnar nerve or to produce Horner syndrome with ipsilateral enophthalmos, ptosis, and meiosis, and anhidrosis. So on the side, patients will have the drop of the upper eyelid, the constriction of the pupil, and difficulty of sweating on one side of the face. Such apical neoplasms are sometimes called Pankhurst's tumor, and the combination of clinical findings is known as Pankhurst's syndrome. So Pankhurst's tumor is often accompanied by destruction of the first and second ribs and sometimes thoracic vertebra. So all this is important to have a great suspicion into what you are dealing with. So patients may come to you with saying, my left eyelid just drooped, or I cannot sweat on this side. There is a sweat on the other side, but this side of my face is not having any sweat. So you should know what to look for. Clinical course, carcinomas of the lung are silent, insidious lesions. It occurs most often between age 40 to 70 years. In some instances, chronic cough and expectoration call attention to still localized resectable diseases. By the time hoarseness, chest pain, superior vena cava syndrome, pericardial or pleural effusion, or persistent segmental atelectasis or Pneumonitis makes it its appearance that is very poor. Too often, the tumor presents with symptoms of emanating from metastasis, like spread to the brain, so mental or neural changes, metastasis to the liver, leading to hepatomegaly, or metastasis to the bones, leading to pain and pathologic fractures. It is variously estimated that 3 to 10% of all patients with lung cancer develop clinical overt paraneoplastic syndromes. So the manifestation is not occurring due to the right cause for the right causes, but for causes other than the normal physiology expected. So tumors are known to bring about paraneoplastic syndromes. Like this includes hypercalcemia caused by secretion of parathyroid hormone related peptides. Cushing-like syndrome. So Cushing syndrome occurs when excess of cortisol produced by the adrenal gland. But maybe these tumors may produce cortisol-like material and cause Cushing syndrome. So when you look at the adrenal, you may not find anything, but the patient may come to you with Cushing syndrome. Syndromes of inappropriate secretion of antidiuretic hormone, neuromuscular syndromes, including myasthenia syndrome, peripheral neuropathies, and polymyositis may occur, clubbing of the fingers, and hypertrophic pulmonary osteoarthropathies, hematologic manifestations, including migratory thrombophlebitis, non-bacterial endocarditis, and disseminated intravascular coagulation may occur. So, from this migratory thrombophlebitis, especially occurs in patients with pancreatic tumors. There was a name I forgot. Trausius sign. So Trausius was a physician who discovered he had a migratory thrombophlebitis. And when he investigated himself, he found out he had pancreatic tumor. Finally, it was given the name Trausius sign, and he died. Hypercalcemia is most often encountered with squamous cell neoplasms, the hematologic syndromes with adenocarcinomas. The remaining syndromes are much more common with the small cell neoplasms or small cell carcinoma. But exceptions may occur. In general, prognosis is poor. The overall 5-year survival rate is around 15%. So the other groups of malignancies you may encounter are bronchial carcinoid or bronchial neuroendocrine tumors. So bronchial carcinoids are thought to arise from the Lechinsky cells or neuroendocrine cells. This line, the bronchial mucosa, and resembles interstitial carcinoids. So the neoplastic cells contain dense core neurosecretory granules in their cytoplasm and rarely may secrete hormonally active polypeptides. These bronchial carcinoids appear as at an early age of patients and represent about 5% of all pulmonary neoplasms. Carcinoids are often resectable and curable. Morphologically, most bronchial carcinoids originate in mid-stem bronchi, like up to 50% of these tumors have metastasized at presentation. Distant metastasis is rare. Histologically, the neoplasms are composed of nests of uniform cells that have regular round nuclei with salt and pepper chromatin, absent or rare mitosis, and latent pleomorphism. So this salt and pepper chromatin comes from the neuroendocrine nature of the lesions. So normally, neuroendocrine cells have this salt and pepper granular nuclear appearance. So whenever the tumor arises, it recapitulates that morphology. Typical carcinoids and atypical carcinoids and small cell carcinomas can be considered to represent a continuum of increasing histology, aggressiveness, and malignant potential within the spectrum of pulmonary. So from typical carcinoid or low-grade neuroendocrine tumor to intermediate grade 2, but the high-grade small cell carcinoid or small cell carcinoma will be considered a spectrum of this disease. So morphologically, you see this arranged nested proliferation, so fairly uniform cells with nestled in paper format. Other benign conditions, those were the malignant so far we have discussed, hamartomas, chondromas, adenochondromas could also occur in the lung. These lesions, the lesion is hard, white, and well circumscribed, and is discovered as an isolated point lesion on chest X-ray. It is composed of nodules of cartilage with foldings and clefts lined with bronchial and bronchial epithelium. From the name, you can understand their origin. So the difference is it's benign, so it's well circumscribed. You see it being circumscribed in radiology. You see this well circumscribed, cone-like appearance. Microscopically, you see bland cell-lined glands as well as benign-looking cartilaginous components. The other important groups of malignancies that could occur in the lung are metastatic lesions. So you say most malignancies can go to the lung, right? Because the drainage of the body, the return of the blood from the body goes to the heart and culminate in the lung, right? So the lung could be the site to lodge any malignancy circulating in the body. So the lung is the most common site of metastatic neoplasm. Morphology, the pattern of metastatic growth is variable, but usually multiple discrete nodules, like cannonball lesions, are scattered throughout all lobes. Because the dissemination is hematogenous, you may find it at more than different one site. So you may find showers of involus and multiple sites of involvement by malignancy can be seen. So you can see depositions at various different levels. We call this cannonball-like appearance. You see deposition of multiple malignancies in a single lung. So microscopically, the malignancy resembles the primary origin. If the malignancy comes from the GIT, which was an adenocarcinoma, in the lung, when it's metastasized, it will keep on being an adenocarcinoma. Okay. Here it's a very nice picture. You see vascular channels with this elastic membrane, the intima, and you see this is a lymphatic channel where there is no smooth muscle cell. So in that lymphatic channel, you see metastatic lesion. So this is a lymphatic metastasis. A beautiful section here you can see the malignancy accessing the distal organs through the lymphatic system. So this is all about the lung, what could go wrong, what you should look for, and what you should know. And it will be incomplete talking about the lung without the pleura, so we'll discuss briefly about the pleura. The pleura, most pleural pathologies are secondary complications of underlying disease. So pleural effusion, it is a common manifestation of both primary and secondary pleural diseases. Pleural effusions in the presence of fluid in the pleural space can be either a transudate or an exudate. So when you say transudate, the cellular content is low, while in exudate there is high cellular content. A pleural effusion that is transudate is termed hydrothorax. Hydrothorax from congestive heart failure is probably the most common cause of fluid in the pleural cavity. Other conditions associated with generalized edema, including renal failure and cirrhosis of the liver, may give rise to transudative effusion in the pleural cavity. If the underlying cause is elevated, hydrothorax resolve without permanent alterations. An exudative characterized by protein content greater than 2.9 gram per deciliter and often inflammatory cells suggesting pleuritis occurs, and the four principal causes of pleural exudates are microbial invasions through either direct extension of the pulmonary infection or blood-borne seeding, like suppurative pleuritis or empyema, could be due to the adjacent infection of the lung. Cancers like bronchial carcinomas, metastatic neoplasms to the lung, or pleural surface tumors like mesotheliomas, pulmonary infarction, and viral pleuritis all may cause exudative collection. Other less common cause of exudative pleural effusion are systemic lupus erythematosus, rheumatoid arthritis, or uremia in previous thoracic surgery. Cancer should be suspected in effusions which characteristically are large and frequently bloody, hemorrhagic, and cytologic examination may reveal malignant and inflammatory cells. So, if a patient comes to you with a pleural effusion and the pleural effusion is not resolving, even if you're treating the suspected underlying diseases of the heart or the liver or the kidney, and whenever you tap it, there is mixage of blood, you should always suspect a malignant effusion, and you should order that to be investigated by sending cytologic samples. Fibrinous and hemorrhagic and separating exudates lead to fibrous organization, yielding adhesions or fibrous pleural thickening, and sometimes minimal tumor calcification. So, whenever there is acute inflammation, if it's not treated, it will culminate into forming chronic inflammation, and wherever there is chronic inflammation, the outcome is by default fibrosis and consolidation, irrespective of the site. So, in case of pleural, the same is true. So you see pleural cavity filled with this fluid, with this effusion. And in X-ray, you may see obliteration of the costophrenic angle and dull areas of pneumothorax. Pneumothorax refers to air or other gases in the pleural sac. So whenever there is fluid, we call it hydrothorax or pleural effusion. If there is air in the pulmonary cavity, we call it pneumothorax. It may be spontaneous or traumatic. Spontaneous from bullets occurring in emphysematous lung, or traumatic. If there is penetrating trauma to the chest or traffic accident opening the cavity to the lung. It may occur in young, apparently healthy adults, usually male without any pulmonary disease, like simple or spontaneous pneumothorax. Also, as a result of some thoracic or lung disorders, like secondary pneumothorax. Secondary pneumothorax occurs with rupture of any pulmonary lesion situated close to the pleural surface that allows inspired air to gain access into the pleural cavity, or such pulmonary lesions include emphysema, lung abscess, TB, carcinoma, and many other less common processes, which can bore into the lung parenchyma and into the pleural cavity. There are several possible complications of pneumothorax. It's one of an emergency cases. Pneumothorax should be addressed immediately. A ball valve leak may create a tension pneumothorax that shifts the mediastinum, and compression of pulmonary circulation may follow and may even be fatal. So if the leak seals and the lung is not re-expanded within a few weeks, either spontaneously or through medical or surgical intervention, so much scarring may occur that can never be fully re-expanded. In this case, serious serous fluid collections in the pleural cavity and paid hydropneumothorax with prolonged collapse, the lung becomes vulnerable to infection, as does the pleural cavity when communication between it and the lung persists. So empyema is an important complication of pneumothorax or causing pneumothorax. If the fluid collecting in the pleural cavity is lymphatic fluid, it is called chylothorax, and it is a pleural collection of milky lymphatic fluid containing microglobules or lipid. Pylothorax is most often caused by thoracic duct trauma or obstruction of the secondarily caused rupture of the major lymphatic duct, usually by intrathoracic cancer, minor or secondary mediastinal neoplasms such as lymphomas. So you see the fluids will be milky and different from the clear hypothorax or the bloody hematothorax. Hemothorax is the collection of whole blood in contrast or bloody effusion. In the pleural cavity is a complication of the ruptured intrathoracic aortic aneurysm or vascular trauma. It is almost always fatal. Tumors in the pleural cavity, though very rare, malignant mesothelioma can occur. It is a rare cancer of mesothelial cell, usually arising in the parietal or visceral pleura, although it also occurs much less commonly in the peritoneum and pericardium. It is related to occupational exposure to asbestos, and 50% of individuals with this cancer have a history of exposure to asbestos. The latent period for developing malignant mesothelioma is long, often up to 40 years after initial asbestos exposure, suggesting that multiple somatic genetic events are required for tumorigenic conversion of mesothelial cells. So the combination of cigarette smoking and asbestos exposure greatly increases the risk of bronchial carcinoma, but it does not increase the risk of developing malignant mesothelioma. Morphologically, malignant mesothelioma are often preceded by the extensive pleural fibrosis and plaque formation. These tumors begin in a localized area and in the course of time spread widely either by continuous growth or by diffusely seeding the pleural surface. At autopsy, the affected lung is typically instead by yellowish-white film, initiated by white shell of film, sometimes gelatinous layer of tumor that enters the pleura. And the neoplasm may directly invade the thoracic wall, tissue. So you see, it occurs in the pleural surface and it may encompass and enrich the lung overall by seeding that cavity. Affects the entire lung. Histologically, mesothelioma spawn one to one of these patterns, either they look like epithelial or sarcomatoid or biphasic, where you can see both features of sarcoma and epithelial components like this. So these are nasty looking epithelioid cells where they resemble epithelial cell. Could occur in the pleura, but don't worry about this because it's a very rare disease. Just have to know what could occur. Otherwise, you would rarely see it in your future clinical practice. ተረቴ መልሱ አፌን በዳቦ አብሱ። እንግዲህ ያላችሁት የቀራችሁት I hope you understood. Did you get the message? Anyone? You're welcome, Fenot. Thank you. እኔም አመሰግናለሁ። መልካም የትምህርትና የስራ ጊዜ ይሁንላችሁ።
አንድ ጥያቄ አለ ዶክተር።
አንድ ጥያቄ ያየው መስሎኝ ነበረ።
Worst prognosis ያለው
tumor, no? The worst type of lung tumor with the worst prognosis is a small cell lung carcinoma. Small cell lung, see.
Okay, thank you, doctor. እናመሰግናለን በጣም።
እኔም አመሰግናለሁ። በርቱ። ደህና ሁኑ።
እሺ